NephU community, and welcome to the Hot Topics in Nephrology podcast. I'm Jeff Lockwood with the NephU medical team, here with a guy who, even though it's February and everyone thinks about hearts, he still writes about kidneys, nephrology writer and editor Mark Newman. Every month, Mark keeps us up to date on the latest hot topics in nephrology. And it's interesting, Mark, and you may have already known this, but I learned something about February. The word actually comes from the Latin word februa, which means to cleanse, which is convenient because that's what kidneys do.
They sure do. Remember last month we talked about the pig transplant, and of course that's a cleansing of a different kind. And we talked about the fact that this was the longest pig transplant, longest surviving pig transplant. And so I'm sure when the patient thinks about it and thinks about cleansing, it may have a little bit of a different kind of thinking around it. But we're so glad that she's doing well.
Yeah, it's such a great story and does bring a brand new meaning to cleanse. Now today, we'll focus on two topics. We've got an update to potential cuts being proposed by the Trump administration on medical research fees and some more details from the results of the Kidney Care Choices model. There's some new data from 2023 on the KCC model activity, which is expected soon. But we think the NephU readers might be interested in a closer look at the participants in the first year of this demonstration. So what are we hearing from the National Institutes of Health, Mark?
Well, unusually, the cuts you mentioned are actually being proposed by the National Institutes of Health. And in fact, they went into effect on February 10th. It's unusual, of course, for a federal agency to suggest cuts to its own department. But as we know, the Trump administration has moved to freeze or reduce funding in a number of federal departments, along with layoffs in the workforce. The courts have forced the president to pull back on some of these executive orders, and most recently put a pause on the NIH decision to cut funds that pay research centers and hospitals for the indirect costs of housing and managing these medical research projects.
So the NIH pushed the cuts, but they were directed by the Trump administration.
Yeah, I think that's a good summary. Soon after the reductions were announced, federal judge Angel Kelly blocked the Trump administration, in essence via the NIH, from making the cuts, which would have limited the payments for these indirect costs to 15% of a grant. The judge made the decision after 22 states had sued the Trump administration over the cuts, and a hearing on the case has been scheduled for February 21st. Universities and medical institutions use the money to cover administrative costs, clerical staff, IT support, cybersecurity, and data repositories during the trials, and more when they host or help researchers conduct a clinical trial, according to the lawsuit that was filed by the states. 4 of those states in the lawsuit, by the way, are well known for biomedical research, including Massachusetts, California, Maryland, and New York.
Yeah, those are some pretty big states when it comes to looking at clinical trials, especially. So the Trump administration wants to cap the payment at 15% of the grant that covers these indirect costs for the research center and hospitals that serve as a site for the project.
Yeah, right. And the NIH said these trial management costs can vary by institution, citing one study at Harvard where those trial management costs were as high as 69% of the project. So the concern from critics of this proposal say it could in fact limit research, as fewer centers step up to function as sites because that 15% won't cover their on-site costs. Likewise, it's not clear how the incoming recommendation or appointee that Trump has made to head the National Institutes of Health, how he will handle this situation. Now, those hearings are still somewhat, at least 2 or 3 weeks away yet, but it will be interesting to note if he takes some kind of action.
Sounds like we'll need a follow-up story on this next month. In the meantime, why don't we swing over to value-based care?
Right. So we had talked about the results from the Kidney Care Choices model in a previous podcast, but I thought it would be interesting to look at how this might move forward in the new administration. And as we've mentioned before, the Health and Human Services Secretary, Robert F. Kennedy Jr., is a fan of value-based care. He sees it as the future of healthcare payment under the Medicare and Medicaid programs. So I'm guessing that the demonstrations, like the KCC model that we'll talk about in a minute, and others that work on new healthcare payment research will continue under his administration if, in fact, he wins the nomination.
Well, that is good news. So, what might he be reading about from the results of the first year of the KCC model?
Well, no doubt, if at the end of the 6 years of this demonstration, the conclusions are that value based care is how chronic kidney disease and the end stage renal disease program will be paid for, it will be a major transition for the kidney community.
Well, and we've had that dialysis payment bundle now for almost 15 years. How is this different in how it pays for the cost of patients with CKD and ESKD?
So, what the payments by Medicare have been in the past for dialysis care is under this bundled payment model. And it serves as sort of a capitated payment, similar to the basis of what value based care offers. Physicians and kidney care teams benefit under value based care in the form of financial incentives. And that's really the difference between what's being proposed under value based care and the bundle that we've become used to. And these incentives are provided when care is improved and costs go down. So preventative care is really the core of value-based care. The healthier you keep the patient and avoid diabetes and hypertension and result in expensive hospitalizations, the higher the financial reward for both the medical team and the payer. Under fee-for-service care, you get paid for treating the illness. Under value-based care, the idea is to pay the health plans to avoid the illness, meaning in our interest, kidney failure. And so the big focus of demonstrations like the Kidney Care Choices model is about placing that risk in the hands of providers. They are the experts at patient management. Let them do their job and get rewarded for it.
So, essentially, let the doctors be doctors. Now, I know we're awaiting the fiscal year 2023 data from this model, but who are the big participants in the first year?
Based on the CMMI evaluation of the 2022 data, we had 9 organizations that contracted with CMS as part of the project. The largest are Interwell Health and DaVita. Now, it's good to note that Interwell Health is a separate entity, but has an affiliation with Fresenius Medical Care. So, in essence, the 2 largest kidney care providers in the U.S. are represented in this model. Other participants include dialysis providers like Dialysis Clinic Inc., Satellite Healthcare, and U.S. Renal Care, as well as some value-based care organizations like Evergreen Nephrology, Strive Health, and Panoramic Health. So let's look a little bit at this data. So from the first year, of course, we have those results, and we're waiting for that 2023 data, as you mentioned. What we do know for those participants in that first year, there are 30 physician practices and 291 nephrology professionals in the Kidney Care First model. Kidney Care First model is for physicians and their practices only, so it doesn't involve dialysis providers and it doesn't involve transplant centers per se. We also had in that first year 55 kidney care entities, KCEs, in the comprehensive kidney care contracting model. And obviously a bigger, longer title for that group, and that's because it's more comprehensive. So this includes dialysis and transplant centers. In this group, they had a total of 2,565 nephrology professionals involved in the Kidney Care First model, and we have 133 transplant providers and 2,000 dialysis facilities in the comprehensive kidney care contract model. So obviously, when you expand the model to include dialysis centers and transplant centers, the number of people, the number of professionals is larger. But I think this is a key point, Jeff. 30% of model eligible Medicare fee-for-service beneficiaries are aligned to the Kidney Care Choices model. So, in essence, this study is going to represent, after that 6 years, we'll have data from 30% of the dialysis patient population that's under the traditional fee-for-service care. So that's a pretty robust sample size.
I think you're right. This really does point to the robustness of the demonstration. And in 6 years, if we can cover 30% of the patient population that's under the traditional fee-for-service care, that's quite a good number, really. The results from this group should be able to show if value-based care does a better job of patient management.
Yeah, I agree. And I think as soon as we get that fiscal year 23 data and it's out and available, we'll be able to compare that with the 2022 data. And by the way, the report for that first year, of course, is available from Medicare. You can simply do a search for Kidney Care Choices model. There's a whole website through Medicare that's available. And that report is available along with other information about the participants. So there's a lot of great, like I said, 6 years. We're going to be looking down the road on this. It's really going to be a major transition if, in fact, the results show improved care. And of course, Medicare, like any payer, wants to be able to see costs go down as well.
We're always looking for decreased costs and improvement in patient care. So sounds like there's a plan. And, like always, more to come on many fronts. Well, Mark, thanks for joining us to give an update to some of the potential cuts being proposed by the Trump administration on some of those medical research fees and some more details from the results of that Kidney Care Choices model. I'm really looking forward to see what we have from that next report that'll be coming out. And thank you to the NephU community for listening in. Be sure to like and subscribe to the NephU podcast and all the major podcast hubs. Hope you guys enjoyed the conversation. Be sure to join us next month so Mark can keep us up to date with the latest hot topics in nephrology.